On that note, Elisa, if you could tell us a little bit more about the demographics of your group, because there are a lot of different groups of people who call themselves Hispanics or are labeled Hispanics, and also give us some feeling of the socioeconomic of the community that was in your focus group.
When living donors are screened to become a donor, there's a very thorough evaluation process, and they are healthier than the general population prior to donating. Okay. After donating, certainly some do develop risk factors, such as they are at a higher risk. They have greater chances of developing hypertension or diabetes, which are risk factors for end-stage kidney disease.
So, I mean, I'm more than happy to show you the Segev paper, but yes, there are risk factors for developing end-stage kidney disease that donors experience, but in terms of longevity. But yeah, certainly there are donors who died, and I'm not negating that at all. With regard to the demographics, I don't have my demographic table in my pocket or anything, so I don't have it in my slide set. But I would say that there were a lot of first generation participants, those who had either, first or second generation, people who had come from Mexico in particular. That was a large patient population as far as nationality. And age-wise, they were, I would say, well, it really depends on the patient group, because, dialysis and the kidney transplant recipients are, going to be a little bit on the middle-aged range. But I don't have it handy to give you the full specs, so sorry.
Thanks for reminding us once again about the enormous power of television to inform. I want to ask you about the dark side, if you will. We did a study a while back looking at local television news and health misinformation presented on the local news. You told us when things were done right. I assume you saw lots of examples when things were not done right. And I was wondering how common that was and what effect that might have.
So it's kind of funny that you should say that. You're absolutely right. I actually do a blog on film and bioethics called Bioethics Screen Reflections that you're all welcome to go to. This particular approach came from film school. When I was a film student, my supervisor would sit at the editing table and he would see all kinds of atrocities that I had done to my film, cut them wrong or whatever, and he would sit there for 2 hours and he would go, that right there, you got it, that right there, you got it. And finally, after 6 months, I asked him why. And he said, I don't care about when you don't do it right. I do not want to reinforce that. I want to reinforce when you get it just right, and then we'll just keep filling in the holes. So that was an intentional approach. There's lots of bad stuff. One of the things about scripted entertainment TV is you do have a chance, because it's scripted, to actually influence what ends up on the screen. You don't have that chance in things that aren't scripted. People are going to say what they say, and then you need to interpret it and add things to it. It can be very, very dangerous. But it is ubiquitous, so it's not something we can avoid as bioethicists. We have to get into the fray, and it's been 20 years, and few of us have done that. We've done a lot more in documentary, information broadcast TV, but around the world, a lot of the work in AIDS, a lot of the work in nutrition, a lot of the work in education. I encourage you to see To Educate a Girl, which is the campaign to educate young women and girls, since they're the most illiterate populations in the world. These are public health campaigns that are based on film and documentary film, but they're done in the storyline. They're the narratives of individual people.
Hi, my name is Melissa. I'm a pediatric resident at UIC. Is this working? No. So my question is for Dr. Navari. So I think you mentioned that you would actually recommend not bringing in a device when you're, I think you mentioned not bringing in a device in the patient encounter, which I would also support, except that now, especially in the outpatient setting, we're sort of like obligated. I mean, with CPOE now, we have to have a device. We have to be able to order things in the moment, or else like our vaccines won't get done. The flow just doesn't work, or at least the flow has been like devised with us using devices basically during the patient encounter. So I think, I guess my question is, have you considered working with students on how to do that effectively and still be a good communicator? Because I mean, I personally feel like I bring in my device and I can still communicate effectively with my patients, but kind of working on that from early on.
Well, I think there's no absolutes. The reason we do this with the students is because we want to bring this to their awareness. I mean, we're all using electronic medical records now, and they're using them as well. But the thing is, I have so many patient complaints about physicians who talk to and treat their computer and don't really talk to the patients. And so I think that depending on what your style is, do I think it's possible to bring a laptop or an iPad into the exam room and communicate well with a patient? Yes, but I think that physicians need to be aware of the fact that I'm not sure that patients like that, and I think that a lot of the patients think that they're not being listened to, and the physicians are looking at getting that encounter done electronically and not listening to them. So I think it's whatever your style is, and I think it probably can be done, but it really can be a distraction. And so my own style is that I basically review the patient's record before I go into the room, and then once I'm finished with the patient, I sort of enter the information either after the encounter or later. But so I think it's just people should just be aware of the fact that it can be a significant distraction and decrease the quality of the patient-physician encounter.
Hi, I'm Grace Shaw. I'm a visiting fourth-year medical student from Kansas City University of Medicine and Biosciences. And I'm also going for my master's in bioethics, and I think that what you're doing with medical students is the aim of what we're trying to do in our bioethics program. I was wondering, for your pediatric rotation and the questions that you have medical students ask, I'm interested in pediatric end-of-life care, and I was wondering if you would ever ask the medical students, how to have the end-of-life discussion with the pediatric population and their parents.
Well, at the level that we're talking about this medical student first and second year, we basically have a general end-of-life care discussion, and in the issues about withdrawing and withholding treatment, we use Dr. Ziegler's four-pronged approach of medical indications and quality of life and patient preferences and external factors. We don't specifically go into pediatric end-of-life care in this particular medical student program. If somebody is doing a fourth-year elective and they know they're going to do a residency in pediatrics, I think it would be reasonable to sort of, if they're going to rotate through a NICU, they may need to have that kind of experience. But that really isn't in our program at this level, but maybe later on it could be.
My question is also for Dr. Rudolph Navari. I'm Preston Reynolds. I'm at the University of Virginia. One thing we know from the professionalism literature is that students get this training in their first and second year, and now you're offering it in their third and fourth year. And yet they're seeing the residents and the faculty around them not model these communication behaviors. And in fact, some of that skill level that's developed in the early years is actually eroded because it's not reinforced in the clinical training environment. So question one is, what are you doing to counteract those learning environment forces? And secondly, if a third of your students are not developing this core competence, which we now know is an ACGME core competence, should they be graduated from medical school? And if you are concerned about their level of skills, what kind of remediation are you doing to ensure that by the time they go on to that next level of clinical training, they are actually competent to perform at a level that's necessary in a clinical encounter?
So the answer to your first question is we also have a clinical faculty development in communication skills. Now, you can require medical students to take certain courses, but it's difficult to require faculty to develop these skills. But we're certainly aware of that. We're certainly aware of that, and we're trying to convince our medical school administration to put these programs in for residents, because the residents, of course, come from all over, and the residents come from all over, and so they may have good skills and they may not. So we're implementing it for the medical students, we're offering it to the faculty, and we're trying to put some pressure on training residents. Obviously, I'm interested in communication skills and developing them, and so, you know, the fourth-year medical students have to go to a regional center and have to interview 15 patients and pass those. If they don't pass that, they have to repeat and do it again. And we have some programs for those students. But obviously, the accreditation bodies think it's important. That's why they put in the 15-patient examination in the fourth year a few years ago, which, by the way, when it first came out, the AMA opposed it.
My question is to Dr. Helft. Can you hear me? Yeah. I think these seat mics are working. Paul, I like the way you've begun your study in terms of nurses communicating prognosis to patients, but what challenges or barriers do you envision to making, but before you can actually achieve that, do you have in mind the steps that have to be overcome so that the practice is, one, beneficial and effective with patients, and two, accepted by the oncology community?
Yeah, the qualitative study, one of its primary intentions was try to get a much deeper understanding of what the actual barriers were, and then what the successful strategies that experienced nurses could tell us they had employed, because many very experienced nurses have already figured out their workarounds. And I didn't go into this, but what we actually figured out is that they've developed both direct and indirect workarounds for the problem. And so, but the main barriers have to do with, nurses' sense of scope of practice, which is, I think, a major one. That is, I can walk in a room and talk about prognosis. I feel that's completely within my scope of practice, and so forth and so on. But we found in our national survey, and then in the qualitative piece as well, is that there's fairly broad disagreement, or not so much disagreement as lack of agreement, on whether that actually falls in and to what extent it does. So that's the broader definition of that, I think, would bring some clarity to the practice. The second is that, and I never meant to imply, although maybe I did, that we never, even I, who've sort of given up in some ways on my colleagues, didn't feel that nurses would then, become the replacement for, because that clearly, redefines nurses' roles in a major way. But they are well situated to do things like open up a conversation that wouldn't have happened otherwise. So, I mean, it's been my own experience that, colleagues who are, for example, reluctant to discuss a terrible prognosis with somebody who's actively dying because they fear that they're going to take away hope or devastate them, or they can't deal with the emotion or whatever, are much better at it if you say, Mrs. Jones is really ready to talk about hospice.
I mean, you remember the failure of the support study with enormous investment in energy, which tried to use nurses as the link between the patients and the doctors, and that study, which was heavily invested in, just fell flat. I wouldn't want to replicate that model, that failed model.
Well, and I think it's important to carefully understand what the support study, what intervention was all about. I mean, I think a simplistic understanding is that it was a nursing intervention, but I really think it isn't a nursing intervention. Nurses were actually used as a tool to sort of gather prognostic understanding and preferences, communicate them back to physicians, and then the link was supposed to come back between the physician and the patient. So they weren't, they weren't exercising their own autonomous relationship with the patients in the support study. And I think that's a key distinction, that nurses, I have come to understand the bedside nurse as a, key autonomous actor and who has his or her own independent relationship. And to harness the power of us together, I think is...
I'll just shout, Michael Green from Penn State. Just a quick follow-up comment about this devices in the exam room issue. I think we have it backwards when we think we're going to teach, put us as the older people in the room, we're going to teach the medical students about how to appropriately use technology in a medical encounter. I think the medical students have a lot to teach us because they're native speakers and we're not. And we should actually tap into their wisdom and experience with social media and other technologies and how it's going to impact the patient encounter. Because I think we're not going to ever be the teachers in this.
I just want to make a comment about that. I have learned several things about those devices from my younger colleagues, and among those things are that there are some excellent apps for translation. So I'm from San Francisco. I've been caring for Chinese people. I've been caring for, you name it, we're there in San Francisco in a small group of people. There's 1 million people in the whole city. So the result of being able to do this, or being able to train a patient how to use the Mayo Clinic meditation app while I'm there is very important. But I think that the point is well taken, that if you aren't comfortable with doing that, and you're messing around with the computer and you're looking at the computer screen instead of saying, here, let me show you something, right? Or I'm going to say this in English and it's going to say it back to you in Chinese, in a dialect that's only spoken in rural countries and rural areas. So you're right, but I think it is that generational fuse that has to happen, and I think that was the reason. So that's the small screen. I'm into all the screens.
So I agree with you, and we encourage students to have iPads or iPhones for information gathering and recording. I'm just saying that maybe we should be using these outside the room between the medical student and the attending to discuss various topics. And you have these devices which you can have instant information, and while you're asking the question, they'll open it up and give you the answer on their device. I'm just saying, let's not have the device interfere with the patient-physician communication.
Larry, you have the last words.
Thank you. I have a question for everybody, but I'll just do one. This question of ACGME communication skills and everything that you're teaching, and a third of your patients or your students that are failing, if you will. There's a significant number of our colleagues that don't interact with patients, whether it be pathologists or radiologists. If we have a student that comes through that has 2 left hands and has no technical skills, we advise them not to go into surgery or an intervention that needs their hands. Do you take these students that really have a difficulty with communication with patients and guide them to not take care of patients, but do something else?
I think it's a very, very good point. What I've noticed is, with an empirical observation, they self-select those disciplines. They really do.
The important thing there is if they don't, the question of you graduate them to be, I mean, everybody has the license to be a physician, surgeon, or whatever, so you can sort of do anything, but self-selecting and guiding are 2 different things.
On that note, I want to thank the panel. I want to thank the audience. And a special thanks to Mark Siegler, who is the sort of the center of all of it. Thank you all very much for coming. I hope to see you at the party.